Last section, hang with me. I know we're getting sleepies, but at least we already did the throat lecture. So after this, we got to do these two things. They'll be pretty quick, and then we're out of here. Now, I got to remind you, tomorrow we have tutoring over the 12 leads. It'll be on Teams. I think has the invite been sent out? Yeah? So if not, Jeff will do that. I don't have access to y'all's class on Canvas, but we're going to send that out. It'll be 9 o'clock in this room if you want to come here. Now, there might be some value of being here, but I will have to sit at the desk and write on my iPad. The game plan is to quickly review 12 leads and to quickly review 12 leads. I like watching all sorts of weird stuff on here, but here we go. 12 leads and to be reviewing your last homework, those 20 strips. So that would be an opportunity to do that. And then if you have something in specific, oh, I really just don't understand LVH or whatever, that's your time to ask me. So it's going to go from roughly 9 to 11-ish. So again, you can come here or you can watch it on Teams, and it will be recorded on Teams. Now, I was heartbroken when I saw 5 views on my excellent video. So if you type in my name into the YouTube, Hunter Harbold, you can find these because these are listed to the public. If you want to watch some EKG review videos, this is from the class that we had, right? Like months ago, about a month ago actually. So just so you're aware, those do exist, okay? So any questions on that? Tutoring tomorrow, come or not, don't care, but it will be recorded and it will be on Teams. Good?
Yep.
Good, let's keep going. So let's talk about what is this word, Corbin?
Syncope.
Syncope, not cinco. Right, that's wrong. Syncope. Okay, so it's a medical word for fainting, sudden loss of consciousness. So this can be a short interruption in blood flow to the brain. And guess what happens when the brain doesn't get blood flow? It quits working, so you pass out. Right? So there's a lot of different causes to this too. I should say it's not always brain. It could be heart. But you can get this from bradycardia, you could rub on someone's carotid sinus and have them pass out. So any type of arrhythmia, cardiomyopathy, MI, dehydration, hypoglycemia, pulmonary embolism. What's a vasovagal response, Taylor? Vasovagal response.
Like when your pressure drops and your heart rate goes up?
Kinda. That's more of like orthostatic hypotension, right?
Yeah.
When you kind of stand up too quick and... So, what were you saying?
So does it happen when people are in the restroom normally?
Yeah, on the toilet. Remember the vagus nerve runs through the back of your throat, down through your diaphragm, down next to your esophagus. So when you're squeezing a big duke out and you're pushing on your diaphragm onto your vagus nerve, you stimulate your parasympathetic nervous system. It's a vasovagal reaction. You pass out. Okay? So I don't know why we run a lot of calls with people on toilets, but this is probably a good reason. It's vasovagal responses. You know what I'm saying?
Yep.
We run a lot of calls on people on the toilet. Yeah.
Like out of 10, like 1 out of 10.
It's too much. Yeah. Per capita, way too much on the toilet.
Needs to be like 1 out of 10.
Yeah. So code brown. So just be aware. It could be a patient that goes from a sitting to standing position. That's probably more like what Taylor's describing, orthostatic hypotension. Cardiac arrhythmias, especially in older adults, and this could be difficult to differentiate between seizures if not witnessed. You don't need to know the name, but there's something called an Adam-Stokes attack where, have you all ever seen like a boxer or someone pass out where they do make a little bit of a seizure motion? That's brainstem hypoxia, and that can be confused as a seizure. It's not a seizure though, okay? I'll say that again. Hypoxia, the first few seconds of it, they can jitter, and it looks like a seizure, but it's not a real seizure, okay? You've probably seen this in boxers or street fights when someone gets knocked out, right? It's an Adam-Stokes attack is the name of it. Now, incontinence is possible, just like in seizures. So incontinence is an involuntary loss of control of your bowels, okay? Or you could pee as well. It's not just poop. It could be both, who knows? But yeah, prodromal signs and symptoms. What does that sound like to you? Prodromal signs and symptoms. This is the beforehand. Oh, don't tell us. Dizziness, weakness, short of breath. So prodromal means like this is before you're going to faint. It might make sense that you're dizzy, weak, short of breath, chest pain, headache, loss of vision, right? Has anybody got close to passing out or passed out where you literally get tunnel vision? I have. It's scary. But yeah, just be aware, okay? Now, of course, this is going to be correct the underlying cause. If they're hypoglycemic, give sugar. If they're hypovolemic, give them volume, right? If they're arrhythmic, fix the arrhythmia. So we see a lot of this, actually, a lot of syncope, okay? Now, Your books, I would take a picture of this actually because they ask these and they're pretty easy questions. These are different headaches. And you might think, I know what a migraine is, but do you know what a cluster headache is? Maybe not. So let's talk about a cluster headache. This is also known as a suicide headache. It's typically men, around my age, 20 to 40s. And what happens is that the classic vignette is the patient will wake up in the middle of the night with excruciating eye pain. Okay? And it lasts about 30 minutes. And they can also have lacrimation, tearing of the eyes, because that nerve is so overstimulated they could tear up. Okay? So that is the classic presentation of a cluster headache. Male, 20 to 40s, wakes up at night with extreme pain behind the eye, may or may not have lacrimation. Those are the ones that you need to know for a cluster headache. Now, a migraine, actually more common in females, and they may even present with an aura. Does anyone want to take a stab at what an aura is?
It's
Jesse?
like a prerequisite to like or I don't know if that's the right word, but a pre-symptom.
Yeah,
migraine.
it's a
So,
pre-symptom.
some people get like a taste or
Exactly.
Personally, I get like wavy kind of vision
Yep.
a little bit.
So they can be anything. Taste, smell. Some people say they taste pennies in their mouth. Who knows? Where else do we get auras?
Seizures.
Seizures. Yeah, good. So it may or may not have an aura, but this is irritation of cranial nerve 5. Remember trigeminal neuralgia, right? It can get irritated, but it's painful. It's usually one side. It's kind of predictable. You don't need to know the treatments of this, by the way, over here. This is more medical school stuff, but I like the schematics of this one in my book. So yeah, just be generally aware. This typically is females, usually one side of the face, and it can last for a long time, 4 hours to 72 hours. That's a long time compared to a cluster headache. So that's one way to differentiate the two. Migraines can last a very long time. Now, a tension headache, this is what y'all give me, I'm just kidding. So this is from stress, this is paramedic school, right? Where you're just kind of like, you have that tension, it could be band-like around your head, your forehead. And this one really doesn't discriminate male versus female, but it's you know, it can last 30 minutes to 6 hours, and we've all had this. This is your standard headache, right? Tension headache, it's usually caused by stress, okay? That's pretty much it, and we're going to end up talking about this in redundancy, but not very long, okay? So again, muscle or a tension headache, you can get that stiff jaw, neck, and you start, this is from stress. And when people are just uptight all day and all their muscles are tight, they have tension, it can cause a headache, okay? So you may not even realize you're stressed out, and this can happen. Like I said, this is paramedic school. Now, migraine headaches, these are multifactorial. Like I said, they could last several days. It's usually pain on one side of the head. Blood vessel size actually plays a role in this. A lot of our treatments, calcium channel blockers like verapamil, propranolol, they go in there and try to change vessel diameters to try to make this better. Serotonin is actually used to try to treat this, okay? So the patient may prefer darkness and quiet. What does the word photophobia mean? That was on the previous slide. Photo, light, phobia. You're afraid of light, right? Because light can make migraines worse, so can loud sounds. Okay, cluster headache. Again, I wrote it on here for you. It's classically a guy who awakes from sleep with severe headache and pain behind his eye with or without lacrimation. Okay? So these usually will only last 30 to 45 minutes. All right? Sinus headache, we all get these, maybe not in the summertime, but this is, so your sinuses are fairly poorly innervated, right? There's not a lot of innervation within the inside your sinuses, but what we will feel is pressure. So that pressure can build up irritation and will feel a headache, but it's really your sinuses. And this is a pretty, we've all had this as well, unfortunately. But yeah, it might be accompanied with postnasal drip, so dripping from your nasal area down into the back of your throat. This will sometimes cause a sore throat, and you may or may not have nasal discharge. All right? So the management, you're just going to treat the patient, Now, they get real hung up on promethazine and ondansetron. So promethazine, Phenergan, blocks delta 2. And where's my brain, actually? Can I see it just real quick? I was going to show you something kind of worth knowing. Yeah, thank you. So there happens to be an area right here called your area postrema, which you don't need to know the name of that, but okay, there's this blood-brain barrier that's wrapped around the brain, so toxins can't get inside your brain by design, okay? Now, there's an area that is not wrapped up in the blood-brain barrier, area postrema on your brainstem, and what happens is it's constantly sampling your blood. So when you take too many shots of tequila, and it's like, oh wow, that's toxic, I need to vomit, that's coming from that area, okay? Same thing, if you drink gasoline or ethylene glycol, or whatever, and you feel like you need to vomit, it's because it was sampled right there. Now, we have drugs that will specifically go there and block mediators. I want you to actually know is promethazine phenergan. Oh, what just happened? Promethazine phenergan will specifically block dopamine within this area. And it's actually your D2 receptors. And ondansetron will block serotonin. These are very common drugs, okay? So these drugs will fix nausea and vomiting, okay? And they go to the area postrema and they block them off to where hopefully you're not as nauseated. These do pop up. You know, I know men are wells, you also carry promethazine. Have y'all heard the PERT, as the kids call it, right? Promethazine, right? It's because it blocks delta 2, so it causes drowsiness. And when you throw that on with some alcohol, you have a good time, right? So that's why they will mix the two, alcohol and promethazine, because it gives you like this like weird feeling high. Same thing if you were to use promethazine with Benadryl or promethazine with morphine, it potentiates. What's potentiation?
It can increase the effects.
Right, 2 plus 2 does not equal 4. 2 plus 2 might equal 5, 6, 7. That's potentiation, right? Okay. So ondansetron is Zofran, very common drug. Does anybody know the dose of Zofran?
It's 4.
4, good. Now what's the dose of morphine that we give with it? 4. 4 and 4, good. All right. Now moving forward, dementia. What I want you to know about dementia is a patient with dementia will not know they're confused. And that sounds weird. I'll give you an example versus normal aging. Lady comes to your clinic, says, I keep walking into rooms and forgetting while I'm there, and I'm misplacing my mail. That is normal aging. She is coming to you and saying, I am confused. Right? That's normal. We all do that right now. What is dementia is the patient that is brought to the clinic by her daughter and says, my mom is walking into rooms and she does not know why she's there. She is confused. And you ask the patient, do you feel confused? And she says, no. Dementia patients don't know that they're confused. Do you see the difference between the two? Mm-hmm. Dementia patients are generally not aware that they're confused. Or they're not complaining that they're confused. Normal aging, they will complain that they're confused. There is a difference between the two. All right? So in dementia, though, that you can have deterioration and it's a chronic condition. Dementia doesn't happen over hours or days. It's years and years and years. Okay? But you can have a change in your memory, your personality, your language skills, your perception, reasoning, judgment. So in severe cases of dementia, they might lose apathy. So they might lose caring for other people, or I won't step into that. But yeah, there's different causes that can happen with dementia. Versus, we're going to talk about delirium. Delirium is an acute loss of memory, and these are what we run more often is someone who's delirious. It is an acute loss of memory. So you might see delirium in one example that the book gives in here is hypoglycemia, perhaps. But delirium is acute. So if they describe to you someone who is acutely, within the last day, confused, that's delirium. That's not dementia. Make sense? Mm-hmm. Yeah? All right. So I have no clue why your book cares so much about Wernicke-Korsakoff syndrome, but I need to explain it. Huh? Have y'all ever heard of Wernicke-Korsakoff syndrome? No. Okay, it's annoying, and it doesn't happen in the United States anymore, but your paramedic book cares about it. So let's go back 10 years ago. There used to be a standard when you ran a hypoglycemic patient, you would walk into the house, see their sugar's 30, and you would give them 100 milligrams of thiamine, also known as vitamin B1. And then you would give them glucose. Yeah, not that long ago we were doing this. Like when I started EMS, we were doing this. Okay? The reason for this is alcoholics are malnourished. A chronic alcoholic, where they spend all their monies on drink, they're typically malnourished and they don't get enough thiamine, also known as vitamin B1. Okay? So what happens is, when they're not getting enough vitamin B1, you have to have B1 to convert glucose, like dextrose, to glucose. So if you give someone glucose without thiamine, vitamin B1 present, in a large bolus, you will destroy a part of the brain called the mammillary bodies, which has to do with memory. Okay, this gets all confusing. And what happens in Wernicke's encephalopathy means the brain swells. So what happens when you don't have enough ATP in the brain? It swells. So, and we need glucose to produce ATP. Makes sense? You see where I'm going with this? Mm-hmm. So what happens is the brain will swell. When it swells, that will then cause damage to the mammillary bodies. That is called Korsakoff psychosis. Okay? This is not me even being fancy with you guys. They actually want you to know just having a general awareness of this. I'm just trying to explain it to you. Now, Korsakoff psychosis has a very typical pattern. It's called confabulations. And it's actually, you'll see this sometimes in Alzheimer's patients. Confabulations is someone makes up a story because they're that confused. They're not making up a story to be funny or to but they're making up a story to try to connect pieces that they can't connect because their memory has been destroyed. They have no long-term memory. They cannot remember, their memory is only about 5 minutes, and they don't remember their past life, but it's weird. Their intellect's still intact. So there's like this old video on the internet, this guy's an engineer, he can still do complex math problems, but he doesn't remember having kids or being married, and he doesn't remember your name a minute from now. That's Korsakoff psychosis. So what I'm telling you, if you take one thing from this, alcoholics, you give them thiamine before you give them dextrose in cases of hypoglycemia. If you don't, you run a risk of Wernicke's encephalopathy, which will then lead to Korsakoff psychosis. That is Wernicke-Korsakoff syndrome, okay? Not even me being fancy. These are things that sometimes they'll ask. I will tell you, most systems don't give thiamine anymore before dextrose because the chance of having someone living in the United States without enough thiamine is very, very low. Okay, this doesn't happen much anymore, but it used to. Okay, everybody good with that?
Yeah.
Good. Alzheimer's disease. Alzheimer's disease is actually misfolded protein called amyloid plaques that end up in the brain, and they get misfolded. Okay, that's really what you need to know. But in Alzheimer's disease, you get an atrophied brain. What does that sound like to you?
Atrophy.
A smaller brain. Good. And you obviously have impaired memory, executive function, emotion, all those things. Okay. Don't confuse dementia with delirium. And like I said, delirium is acute. If they tell you someone has an acute memory loss, that is delirium. It is not dementia. Don't pick the sucker answer. Okay. Now, moving forward, dementia could be dismissed as old age. This is very difficult to diagnose. Patients become aggressive or violent. Like I said, I used to work in a nursing home. I've been kicked on, spit on, food thrown on me. You know, it's just a part of the disease process for them, unfortunately. Confusion is the hallmark sign, but also they could affect their ability to swallow. It's not uncommon in a nursing home to see someone on pureed diet. Mm-hmm. Why is that? They lack the coordination to swallow. Or thickened liquids. They'll be drinking honey-thick coffee, where you put gelatin in there to thicken it. It's because they can't swallow properly, so they run the risk of choking. Now, I hate that your book put this in here, but I'm going to cover this very quickly. You can go back and watch the video if you want. Again, Alzheimer's disease is buildup of plaques, amyloid plaques within the brain. It happens over a period of years. As you can imagine, you're going to have a decrease in attention and judgment and memory. Makes sense. I think we know a lot about Alzheimer's disease in this class. Now, Pick's disease is vascular dementia. So there's a vascular disease that is causing their dementia. This happens much quicker, and it tends to be frontal and temporal lobes. Interestingly, Pick's disease you can end up with you lose inhibition, you lose your personality per se, your emotions. The classic example of Pick's disease is the 68-year-old male who starts masturbating at McDonald's. Wow. Because he lost his inhibition. We're inhibited from doing something like that, but he's not inhibited to not do that. So that's a classic that they'll do hypersexual things. They'll slap someone on the butt or something like that because they're not inhibited. Okay, that's Pick's disease. It's like dementia that happens quicker. Huntington disease, this is it's memory loss, and again, it's misfolded proteins, but this will happen over years and years, and it gets worse from generation to generation. I would say the big one on this is tics, movements, and aggression. They tend to be pretty aggressive. Creutzfeldt-Jakob disease, I know that says with a J, but it's actually Creutzfeldt-Jakob disease. These are prions, if I were to build a weapon, this is what it would be. It's proteins that act like viruses. Just a straight up protein from a cow. This is mad cow disease. From a cow, they get in your bloodstream and they go up to your brain, and they call it spongiform encephalopathy. So your brain literally turns to sponge-like consistency because these weird proteins can replicate and cause holes in your brain. Terrifying disorder. As you can imagine, this doesn't take very long to kill you. Okay? This doesn't happen a lot in the world. Also, cannibals, kuru, right? People that eat people. This is the same thing. It's on the same spectrum, I should say. Okay? Very scary. I talked a lot about Wernicke's encephalopathy and AIDS dementia. Don't care. Okay? Any questions on those? Good. We talked about dementia. Good, that's what I was telling you. Wernicke's encephalopathy, they want you to know, alcoholic or malnourished patient, we administer thiamine, also known as vitamin B1, prior to administering D50 or glucagon. If we don't, their brain can swell. When their brain swells, they lose their memory. All right, let's talk about neoplasms. Neoplasms are tumors. These are rather unfortunate. And these can produce seizures, stroke-like symptoms. In fact, I'd say 9 times out of 10 when EMS get calls, it's a new onset seizure, okay? So, of course, it's in a confined vault. Also be aware it's not just the brain, it could also be the spinal cord, okay? And they can metastasize. What is a metastatic neoplasm? It's tumors that went from like the lungs or the ovary or the kidney that made their way up to the brain. Makes sense, right? Metastasis, okay? It moved. So yeah, tumors can spread. I just threw up some of the more common examples up here, and I want to point out why these are more common. Do neurons replicate in your brain?
No.
No. What is cancer? It's uncontrolled replication. What does replicate? Your meninges, your astrocytes, and your pituitary gland, because those are not neurons. So we typically get tumors from one of these 3 things in the brain. It is exceptionally rare to be anything else. Meningioma, right? A mass of the meninges, okay? That's what they're showing you here. A glioma are astrocytes. You can get astrocytoma, right? A pituitary. These are fairly common, especially in children, okay? So you don't have to know the names of these. I'm just pointing out, neurons don't cause cancer. It's the other stuff that will cause cancer, unfortunately. So symptoms, as you predict, increase in intracranial pressure, headaches, nausea, vomiting, seizures, ataxia, change in altered mental status, stroke-like symptoms, right? They can also have, especially if it's in the spine, back pain, weakness, ataxia, remember, loss of coordination, loss of limb sensation, incontinence, and they could even have deformity of their spine, okay? So yeah, this is supportive care really. Watch for status epilepticus, administer benzodiazepines if they're seizing, protect their limbs from injury. Kind of self-explanatory. There's not much we can do pre-hospital for that, okay? Any questions on those? No? All right, let's get to this last section and then we will call it. Now, I told you about the speaker wire, okay? That can get jacked up in a lot of pathologies, and that's pretty much what we're going to talk about until we're done today. Okay, so think the speaker, does that not make sense to anyone? The insulation of a wire gets jacked up in these disorders for different reasons. So demyelating, this is where you're removing the myelin, and then degeneration is when you're taking away the whole nerve, okay? And motor neuron, that's destruction of a motor neuron. Motor neurons control muscles, okay? They do motor function. Now, I talked about this, and they occasionally ask about the nodes of Ranvier, so let's talk about that. Myelin runs in little blotches. You won't see this with the naked eye, but it runs in blotches, and what it allows is there's a sodium exchange, an ion exchange that happens at these little gaps called the nodes of Ranvier. And when that happens, it speeds up the conduction. Because it is beneficial when you touch a hot stove to pull away really quickly. It is beneficial for your brain to work quickly, so it speeds it up. Okay, I just want to make sure that you're aware. Now, Jesse, who typically has autoimmune conditions? What's the epidemiology on that? This is a stereotypical patient of an autoimmune patient.
Like elderly?
No?
20 to 40-year-old female.
20 to 40-year-old female. They're going to hand it to you, okay? Now, could a 68-year-old female have an autoimmune disease? Yeah, she probably just got it when she was young. Okay, I'm just letting you know. Now, the body will attack its own cells. Someone, rapid fire, name off some autoimmune diseases.
AIDS, psoriasis.
Yeah. What? MS, multiple sclerosis, diabetes type 1.
Psoriasis.
Right? So right, good. Very good. Yeah. What? Good. We're going to talk about that. Okay, you get the point. Lupus, yes. Yes, actually yes. Okay? So these are conditions where your body attacks itself. Everybody good with what autoimmune means, right? Your body is attacking itself. Now, let's talk about multiple sclerosis. Multiple sclerosis is when the oligodendrocyte, which, let me write that out for you. Oligodendrocyte, and this is the myelin of the central nervous system. So when you think this one, you need to think central nervous system. It becomes stripped off. Okay, your body attacks the oligodendrocyte. And what happens is, the very first symptom you'll get is diplopia, double vision. If you think how much coordination it takes for both your eyes to move in unison to the left or right or up or down, it takes a lot of coordination. And when you start stripping that wire away, they don't work in unison anymore. Makes sense, right? Lots of coordination happens through there. Blurred, so consequently, you could also get blurred vision or nystagmus. What is nystagmus?
Bouncing your
It's
eyes.
when your eyes bounce, okay? So same thing with alcoholics, or not alcoholics, someone who's drinking. You ever wondered why they do the light test for horizontal nystagmus? It's because if you're drunk, you can try this at the bar, their eyes will bounce. Bounce, 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 bounce. What's happening is one eye is moving as fast as it should, but the other one's not. So the eyes are trying to get back lined up together constantly. So you end up with bouncing of the eyes. That's horizontal nystagmus. But there's lots of different nystagmuses out there, but that's something to be aware of, okay? Yeah. You can also have like rotary nystagmus, or there's all sorts of nystagmuses, okay? Okay. Muscle weaknesses is dyskinesia, okay? Speech disturbances is dysarthria, okay? It needs to have an R in there. Now, dysarthria, the difference between slurred speech and dysarthria is slow speech because they're having motor dysfunction. It's not that their brain doesn't know what they're trying to say. Their motor's not working fast enough. Like my motor moves fast, I talk too fast. But their motor can't move fast enough. So that's dysarthria, okay? What is vertigo?
Where they're imbalanced.
Spinning.
Yeah, spinning, right? Yeah. Euphoria. I don't know many MS patients that are euphoria, but I didn't take that out. I didn't put that in there either. And electrical sensations. So just like the end of the wire on your base kicker in your truck, right? If you strip out that wire, it might throw some sparks, okay? Sparks. So yeah, it's supportive pre-hospital care. And you're just going to, control their symptoms. If they're nauseated, you give them medication. Okay? Now, any questions on MS? Good. Let's move to Guillain-Barré syndrome. Not Guillain-Barré syndrome, it's Barré. Okay, Guillain-Barré syndrome, it's a fairly rare disease, but I've seen it 3 times working at Cook's. And it's an immune attack that attacks portions of the peripheral nervous system. So I'm going to write that out for you. Peripheral. I misspelled that, but you get the point. Peripheral nervous system, PNS. Now, what happens on this one, it's interesting. It's ascending paralysis. What does that mean? Paralysis starts at their freaking feet and works their way up over a period of like hours or a day or two. Why it happens, we don't know. We think it might be related to certain bacterial infections like Campylobacter, but it happens, okay? Now, ask yourself, someone with ascending paralysis, what do we have to worry about when it gets right about here? Their diaphragm. We have to really start worrying about that. So what might they eventually need? A vent. Now, oddly, as it rises, it can also go back down. Really kind of strange. But this will happen over like hours to days. It's not like boom, boom. You know what I'm saying? Like, it takes a while.
That's scary.
Okay? Now, this is motor weakness.
People clear it.
Some patients don't recover, and they have to live on a vent. But generally what I've seen, it goes up and it goes back down. Okay? That's what they're showing you here. It can lead to paralysis. It typically starts at their legs and works their way up. Ascending paralysis. Okay? That's kind of what I need y'all to know about Guillain-Barré. So yeah, you're going to provide comfort, transport. All these are supportive care. I'm going to quit reading these to you. It's supportive care. If they need to be intubated, we intubate them. If they can't breathe, we breathe for them. If they're nauseated, we treat their nausea. Right? Supportive care, okay? Now, Parkinson's disease, which I'll write this down for you. It's not enough dopamine in the CNS, okay? Gotta know that. It's not me being fancy. Not enough dopamine in the CNS. So what happens? Let me ask you this. Do we carry dopamine on ambulances?
Some do.
Guys, we talked about this. Yes, we carry dopamine. Yeah. It's straight up dopamine. Now, my question is, when we give it, does it cause euphoria and increase memory and...
Don't think so.
No, because it can't cross the blood-brain barrier. Okay, that's number one. Dopamine cannot cross the blood-brain barrier, and this will make more sense in a minute. So what happens is, within the brain, specifically in this general area right here, there's this area called the substantia nigra, the basal ganglia. And it produces the dopamine you need for inside your brain. Because the dopamine produced in your adrenal glands doesn't matter. It won't make it to your brain. It can't cross over. Okay? So, when the substantia nigra is attacked or damaged, You don't produce dopamine. When you don't produce dopamine, you get a predictable set of symptoms. Dopamine is needed for smooth muscle contraction. So you can get what they call cogwheel rigidity. You know, like a ratchet strap? How it's like ta-ta-ta-ta-ta-ta. So if you were to take a Parkinson patient and pull on their arm, it'll look like that. Ta-ta-ta-ta-ta. It's like a ratchet strap. Or they walk with a shuffling gait, right? Like this. And they will have a resting tremor, right? And they might bob their head. And they have what's called a a masked facies. So what happens is that it looks like they're wearing a mask and they have no facial emotion because that takes coordination. That takes control to control your face. So they typically don't have any type of facial reaction. Mad, happy, sad. It's just a mask. Okay? Cerebellar dysfunction is the biggest thing that you need to take from this. And as you can imagine, the cerebellum is involved in all of these emotions. Okay? Now, again, classically these will present. It's gradual, but they'll present with tremor, postural instability, rigidity, specifically cogwheel rigidity, and bradykinesia, slow kinesia movement, right? So slow movement, okay? Now, how this also looks is we can treat this in hospital. We don't treat this pre-hospital, but there's an order of these, right? So it goes phenylalanine to tyrosine, and I'm just pointing something out to you real quick, to L-DOPA, to DOPA, to epi, to norepi, to epi, okay? And there's reactions that happen all along the way for that to happen. Now, L-DOPA all this can cross the blood-brain barrier. So the idea is, if we need more dopamine, but it can't cross the blood-brain barrier, but L-DOPA will, we just give them L-DOPA. And it crosses, and when it crosses, it's converted into dopamine. Makes sense? Another way we treat this is we inhibit the breakdown of dopamine. We just say, fine, we'll just give you more dopamine. The thing that breaks down dopamine, we'll inhibit it. So that's a few ways this is treated. Why am I telling you this? Because someone could theoretically have too much dopamine. How would that present? Hypertension, tachycardia, irritability. Make sense? Yeah? So that's why I'm pointing this out. They had this in here about L-DOPA. Okay? Everybody good with that? Good. All right. Almost done. Hang with me. Let's talk about ALS, Lou Gehrig's disease. So this is most commonly middle-aged men. What's the Spider or the Superman guy? He died of this. Stephen Hawkins too. Stephen Hawkins. But it's something Clark. Yeah, that's him. Yeah, he died of ALS. Remember the ALS the ice bucket challenge? Yeah, whatever. But anyways, what I want you to know is this is where you destroy the spinal cord. Okay, there's sections of the spinal cord, which one's not important. But this is typically men. We don't know why this happens, but Stephen Hawkins is an example of this. What I want you to know about this is they lose motor function, but sensation remains intact. They can still feel. They still have proprioception even, but they lose motor. Yeah. So, and this happens gradually. So they might start off with fatigue and weakness, and then what's fasciculations? It's not just muscle twitching, individual muscle twitchings. We give a medication when we see this. Anyone know? Succinylcholine causes individual muscle twitching. So it's just like this weird spidery looking stuff, okay? And they'll have difficulty doing their routine activities. So that is Lou Gehrig's disease. There is actually a treatment for this, but it's not very effective. But yeah, I mean, this is lethal. These patients die eventually. Could these patients need ventilatory support?
Yeah.
Yeah, they usually die in a vent farm. And they'll die of some type of pneumonia or nosocomial, hospital-acquired infection, right? So just be aware, okay? Again, we might have to take their airway. They could be complicated. They could be trached. They could be vented. Okay. Now, does that mean these patients don't know what's going on with them? No. Stephen Hawkins is brilliant, full-blown ALS. Okay. So again, even sensation of them feeling, that's intact. It's still there. They still experience pain. Okay. Cranial nerve disorders. I'm just going to blow through these because we've talked about them a lot today. This is rare, but it's on here. Okay. Y'all spoke. Acoustic neuroma. So cranial nerve 8 runs off, and you can get a tumor that goes up on your cranial nerve 8. As you can imagine, if there's a tumor on your hearing nerve, what's going to happen? Deafness. Okay? Yeah. Can also happen bilaterally. Bell's palsy, is that a little face or a big face
Big.
paralysis?
Big.
Big face paralysis. Cranial nerve 7 gets paralyzed, okay? Good. And they also can have hyperacusis. Sometimes they'll throw that at you, and that's just like, boom, that's what it is. They lose the ability to taste as well. Cranial nerve 7 involves taste. Glossopharyngeal neuralgia. This is your palate, your throat. Remember the trigeminal neuralgia? But this one happens to be your throat, the back of your throat. You just get random sharp pains for no good reason. Don't care about hemifacial spasm. Now, y'all know who Dana White is at the UFC?
Yeah.
He has Meniere's disease, okay? And what Meniere's disease is you end up, so if I were to go spinning, there is liquid endolymph in my ear, and it turns these hairs in my ear that tells my brain, you're turning this way, right? That makes sense? So that means when you stop spinning, the lymph may still be spinning, and that's why you're still dizzy after you stop spinning. Okay, that's normal. And it happens in your ear, your inner ear, your vestibular cochlear complex. Now, what happens in Meniere's disease, you end up with too much endolymph. So they get vertigo often for no good reason, okay? So just be aware, when you think Meniere's disease, think vertigo, too much endolymph. I know you are tired, see it on your face, but we're almost done. Trigeminal neuralgia, I want you to know, it's not me being fancy, this is also called tic dorsal. It's the name of it. Tic dorsal is the other name for trigeminal neuralgia. And remember, our trigeminal nerve has 3 branches. 1, 2, 3. And it's usually the second-ish branch that causes pain. A gust of wind, a hair brushing up against your face, and it'll cause extreme pain for about 20 seconds for no good reason. Okay, very difficult to treat too. Sometimes they'll go in there and do surgeries and just burn off that nerve. Okay, any questions on those? Good. Okay, this is still talking about vertigo. So vertigo is when you're feeling dizzy for no good reason. Okay, the book wants you to know that you could have the patient turn their head rapidly side to side, and that could cause nystagmus. What's nystagmus?
The bouncing of the
Bouncing of the eyes. And that's kind of as far as I want to go in that. Other than I will say, you can get stones in your ear, okay? And when you get a stone lodged up in one of these semicircular canals, your whole gyrus gets thrown off. When say your horizontal gyrus gets thrown off, you're thrown off at that point. So that will cause vertigo, which will then cause nystagmus. So there's this thing called the Dix-Hall pike maneuver, which they're describing here, where basically you can kind of tilt someone's head in a rapid direction. We don't do this, and it'll clear that otolith, hopefully, and they can fix it. So I'm just letting you know, vertigo, think nystagmus, think dizziness, okay? Moving forward, dystonias. Dys means wrong tone. So that was that image I showed you earlier where someone's kind of locked up like this or something weird. It's bizarre contortions. It occurs for unknown reasons, but we do know that the use of antipsychotics will cause acute dystonia. Okay? Now, the patients can have normal intelligence, they can think clearly, no seizure, right? Normal LC. But I want to, these can happen, okay, these can happen in pathology and they're like that forever, right? It can also happen acutely. And that's why I've worked in systems before where they would allow us to treat acute dystonias. So, how does this present? It'll usually occur within 5 days of starting a new psych medication or changing the dose. So, I told you, think about this for just a second. It's a big tie together. Psych medicines block dopamine in the CNS. When we don't have enough CNS in our central nervous system, when we don't have enough dopamine in our central nervous system, what is that disorder called?
We just went through it.
We just went through it. It starts with a P. Help me. I'm panicking. Parkinson's. Yeah. So what you can end up with is drug-induced Parkinsonism. This will literally cause cogwheel rigidity, right? So you can have a patient, 22-year-old schizophrenic, who is now having Parkinson's syndrome because of this medication. How do you fix it? You stop the medication. You change it to an atypical. But I'm just letting you know, that's one way this can present. Another way this can present is it can cause excessive cholinergics, which is your parasympathetic nervous system, and it tends to lock people up. Oddly enough, you need to know, what is the antidote to an acute dystonia? Write it down. The antidote to an acute dystonia is Benadryl, diphenhydramine. Okay? Not me being fancy. This is literally in MedStar's protocol. Okay? This actually happens. Okay? The antidote to an acute dystonia is diphenhydramine. Everybody good with that? Good? We're almost done. Hang with me, like 10 slides. Encephalitis. So this literally means inflammation of the brain. This happens usually from viral infections, namely herpes. Also West Nile virus. Okay? So just be aware, it's just inflammation of the brain. Compared to meningitis is the outer layer of the brain becomes inflamed. Or this can be bacterial, fungal, or viral. Now, we'll talk about these in some specificity. So, the brain is of course affected by high temperature, that's obvious, and the neurons become impacted. But if the temperature comes too high, you can see a patient hallucinate. You might have seen this by now, right? Fever can cause people to hallucinate. Again, end organ dysfunction. They can become delusional, experience LSD, they can have a febrile seizure. But that slide's wrong actually. So let's talk about just a good old meningitis, okay? Meningitis can present with stiff neck. They will commonly on exams call this nuchal rigidity. Anybody know what a noose is?
Yeah.
It's a thing you tie around your neck, right? So the nuchal will become rigid. How does that present? Something that I actually want you to do in the field is ask the patient, touch your chin down to your chest. When you do that, you're stretching out the meninges. If they're inflamed, the patient will not do that. Make sense? Right? You're stretching out the meninges down your spinal cord and up through your head. Another one, photophobia. We talked about this. You're afraid of light. Lethargy, altered level of consciousness, and seizures. Now, there's a couple tests that, for whatever reason, your book kind of obsesses on. And they're called Koenig and Brzezinski sign. So the idea is, if you were to raise a patient's head up like that, they're going to bring their knees up to try to pull tension off their spinal cord. You see how that's happening? You raise up their head and they're going to bring up their knees to their chest to try to avoid that from hurting. And so that's positive. That means that their meninges are inflamed. Another way this can happen is if you elicit pain by raising their straight leg up. Again, that's putting tension on your spinal cord, and so it's stretching out your meninges and it's going to elicit pain. And that's what they're showing you here. Everyone, does that make sense to everyone? Okay. I'm not even going to talk about all the different causes of these. Just know encephalitis is inflammation of the brain. It's usually a viral infection. West Nile is probably the most common in herpes. Okay. Now, bacterial meningitis, lots of different causes. You don't need to know the causes. They're bacterial. Okay. And viral meningitis, not super common, but Coxsackie actually can happen. Coxsackie. But just be aware. There's viral, bacterial, and fungal meningitis. They all exist. What is meningitis, Matt?
Inflammation
of the meninges. Yes. So guys, literally imagine white blood cell pus sitting on the top of your brain. It's going to cause some pain. It's going to cause some symptoms, right? So bacteria or virus is sitting on top of your brain. Your meninges are literally inflamed. Compared to encephalitis, your actual brain is inflamed. Okay? So there's different tests we can do to figure out which one it is. But I want you to be aware. Meningitis is super contagious. Okay? So this is another one of those examples where you actually want to wear a mask and try to not be all up in that patient's grill. Okay? This is contagious. Can you see this being rather lethal?
Yeah.
Rather lethal. Okay? Especially to our age people. Children tend to do pretty well with this. But the older you get, the more likely you're going to die. Okay? What is septicemia?
It's systemic sepsis, right?
Close. This is some type of infectious agent, emia, in the blood. Infectious agent in the blood. So you end up with bacteria literally in the blood. This is the precursor to sepsis, you are right. But just know the difference between those, okay? We're almost done. Hang with me. Now, again, they're going to hit you. Okay, what they're going to do on an exam, they're going to give you meningitis and say, what do you do? Do you report it?
Yeah.
Right? You report it because you probably will need post-exposure prophylaxis. Again, it's rifampin. But post-exposure prophylaxis when you've been exposed to meningitis. Makes sense? We wear a mask. So if you have a patient saying, my eyes hurt, I can't touch my chin down on my chest, blah, 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 blah. Probably meningitis, okay? So yeah, it's supportive care of the hospital, really, you know. They might be a little bit septic. Again, abscess is a fluid-filled area, and these are all abscesses in the brain. So, as you can imagine, just like neoplasia, this could present with stroke symptoms, seizure, headaches, nausea, vomiting, increased ICP. As you can imagine, it's rather lethal. I will point one thing out. When the brain dies like this, does it regenerate?
No.
No. So this is bad. It's very, very bad when this happens. Okay? And in fact, there's a lot of parasites that can cause stuff like this. So you people that don't like to cook your bear meat or your pork, right? Right? You don't want this. I don't have this is I think the very last slide. Let me just finish on this. Poliomyelitis. So you've probably heard of polio. There hasn't been a case in the United States since 1979. Why? Immunizations and herd immunity. Now this still happens around the world. Okay? It's viral infection. Let me start with that. And it's transmitted fecal-oral route. So this tends to happen in third world countries. And fecal-oral route doesn't mean you're eating ass. It means that you're eating lettuce or water that has poop that has incidentally got on it. It means someone's making your food with maybe some poo-poo on their hands on accident. And it's getting into so it's unhygienic. So where does this happen? Third world countries, poor countries, okay? Doesn't really happen in the United States anymore because what happens is polio is an enterovirus. It goes into your gut first, and then it can progress and attack the motor neurons of your spine, okay? So what happens is then you lose your motor function. And have you ever heard of the iron lung?
Mm-hmm.
They're stuck on a vent for life. This doesn't. They don't get better. Why is that? It's not the peripheral nerve that's destroyed. It's the spinal cord that's destroyed. The central nervous system, known as the spine and brain, they don't regenerate. So they end up on this iron lung for the rest of their life. Pretty bad. Okay.
She's pretty happy to be able to.
Yeah, she's taking it well. So, anyways. This is just supportive care. You just need to be aware. Now, why they're telling you about something that hasn't happened since 1979, I don't know. And probably most people that did have polio have died off by now in the United States. There's probably not very many left.
Because it probably could be a recurrence because people are not vaccinated.
Exactly.
Yeah, I'm worried about that, but
I think there's still, I saw a documentary recently, I think there's
There's
still
like
like
one guy
one
left.
individual who's
Yeah,
still,
in the U.S.
yeah, in the US.
I saw that guy where he was in the iron lung. I think it was a Vice documentary. Yeah.
That's insane.
Yeah, but anyways, bad times. So, you know, and what's interesting about this iron lung is it's working as a diaphragm would. It causes negative pressure, so it draws air out, and then positive pressure. Negative air pressure, positive pressure. And it's inflating and deflating his lungs that way, which is pretty cool. Okay? This is actually the last slide I lied. Okay, peripheral neuropathy. So I want you to know, have you ever heard of diabetics that can't feel their feet? What happens is, there's two reasons. We know that diabetics have vascular disease, right?
Yeah.
So their most peripheral vasculature gets jacked up first. And we have microvasculature that surrounds the nerve. That's the number one way. Number two way is glucose, constant states of high glucose. Okay, glucose can go into myelin without insulin. It's one of the few cells that it can do. So it can go in there, and what follows? Water. So then water will go in there, and it swells up the myelin, and it can cause damage. So those are the two ways this happens. And I just want you to know, there's a lot of different things that can cause peripheral neuropathy. This can present with burning pain, stabbing pain, pins and needles, or no pain at all. They have no sensation. Okay, all of those can present on any level of spectrums. So just know that this commonly happens to diabetics, and what they're pointing out is a diabetic might kick a wall and break their toes and not even know they're broken. So then what ensues? Infection, or their feet are all rotten off and they literally don't even know it's happening. So this actually does happen. You'll actually see this in the real world. Their feet and stuff are just rotten off. It's all cheesy. Gangrene, wet gangrene. And they don't even know. So just be aware that actually happens. Does this only happen in your feet?
Nope.
No, it can happen in your hands, fingers, okay? So what happens, it's called a Charcot-Marie joint, is they bang it into stuff and they don't even know. So they end up with injuries they don't even know about. And that creates its own whole pathology, okay? Now again, this isn't just diabetics. It could be from metabolic disorders, toxins, traumas, previous burns, autoimmune attacks, could be all sorts of stuff, MS. So yeah, it's a progressive condition and it can present with all, and I should point out, it's not just sensation. You can end up with motor dysfunction as well. Your motor neurons are still neurons. So I will say it tends to be these first, and then the very last one to go, because they're bigger, is your motor neurons. Makes sense, right? So a diabetic can end up with weakness in their extremities peripherally because of this. Make sense? Everybody good with that? That's the last slide. We're done. Woo! All right, so we got to do some stuff. Let me turn this.